Hi everyone, it is a great pleasure to be with you today. I'm going to talk about placebo research from a mechanistic and translational point of view. I wanted to stress that the views I express are mine and do not reflect the policy of the University of Maryland and the funding agencies such as the National Institutes of Health. And before starting, I would like to acknowledge the NIH grants and some other state grants that are supportive of my lab. So today we are going to talk about physiological mechanism of placebo effects, the mechanism of placebo effects in chronic pain, and the relevance of learning about placebo effects for clinical trials methodologies. So when we talk about placebo, we all know that placebo are inert substances that have been introduced in medicine to validate new treatments. But placebo effects and placebo responses can refer to different things. Placebo effects refer to changes in neurobiological responses and clinical outcome that result from positive patient expectations, prior positive therapeutic experience, and the overall ritual around the patient. Placebo responses, on the other hand, refer to biases, regression to the mean, natural history, co-intervention that can influence the outcomes. And usually the best way to separate placebo effects from placebo responses is to have the waiting list arm or no intervention arms, and also it helps to measure expectations in both patient and providers. Somehow, clinical trials, placebo research, drug development have been considered different areas of research. In reality, it is important to bridge this gap and try to understand how placebo mechanism can inform clinical trials. So this is an hypothetical scenario where we want to separate outcomes in 4 different arms. Arm A can be the active treatment, B, the positive comparator, C, the placebo, and X, the no intervention arm. The difference between C and X represent the difference that we define as placebo effects. But other differences, for example, B versus C, will be the placebo response. And in this efforts to try to merge placebo research with clinical trials and development, today I would like to start to show what is placebo research, what do we do as neuroscientists when we want to learn more about modulation of outcomes related to neurobiological factors, in particular placebo effects. And towards the end, I will show that patients are responsive to placebo mechanisms as well as other influence related to expectations. So today, we know a lot about placebo research, in particular in the area of pain. We know that there are different ways to learn to modulate expectations. In particular, we can learn as humans from verbal suggestions. This treatment may benefit you. From therapeutic prior experience, being exposed to a treatment that we perceive as efficacious can be helpful in producing placebo effects. Observational effects, contextual effects, and interpersonal interaction between patient and providers. Importantly, when we have this sort of ability to build expectations and learning through different mechanisms, we can activate different circuits in the brain. And I indicate here in blue part of the area that are particularly important in modulating placebo and pain responses. In particular, we know that the ventromedial prefrontal cortex, the dorsolateral prefrontal cortex, can influence some other part of the brain along with the nucleus accumbens and ventral striatum. When we talk about pain signaling, we know that this part in red, including the insula, the anterior cingulate cortex, the medial thalamus, the somatosensory area, allow us to have this complex experience of pain that we can quantify. My pain is 5 out of 10. We can define as unpleasantness, and also we can localize. My pain comes from my hand. So this ability is related to a set of circuits in the brain that can be modulated by our expectations as well as the pain signaling that transmit to the brain the level and the nature of the pain that we are describing. In this sense, the rostroventral medulla, the spinal cord, the periaqueductal gray, these two areas indicated in purple, are extremely important because they function as a sort of hubs where we can have input to increase or decrease the perception of the pain signaling. We understand then that talking about placebo is merely a tool to understand more about the descending pain modulator system and how pain outcomes are eventually modulated by a very complex set of psychosocial learning experience that in general we can frame as placebo mechanism, but the reality is that when we target placebo, we are using a tool to learn more about the descending pain modulator system and how outcomes can be modulated. And in this talk, because we are in a context of rehab, I would like to stress that one of the most powerful mechanisms to create placebo effects in a laboratory setting is to use conditioning and learning mechanisms. This is one example that has been used several times by many researchers across the countries. So we can teach our bodies to respond to placebo. In this case, health participants were coming to the lab. We use an ischemic arm pain model that we call also tourniquet. Patients have this ischemic model where the arm becomes temporarily ischemic to produce this feeling of pain and uncomfortable sensation. Usually participants tolerate this for 10-12 minutes. If we pre-inject morphine, we can induce an increase of pain tolerance to the tourniquet, and again, another administration of morphine 1 week later produces even a larger increase of pain tolerance. Well, week 4, we replace the active treatment morphine with a placebo. And you can see in gray that yet we have an advantage in inducing an increase of pain tolerance. Not as large as morphine, but yet very meaningful clinically and in an experimental setting. And this was not merely a learning experience. In fact, 1 week later, a 1 week washout produced the same response as the baseline. Well, if we pre-inject in a random way people with naloxone, 10 milligram, that is a relatively high dose, we block placebo analgesia induced by preconditioning with morphine. This study suggests that when we use high dose of naloxone, we block mu, delta, kappa receptors for opioids, and we reverse placebo analgesia. Importantly, we also learn that it is possible to somehow teach and train the system to produce a morphine-like response that we can call conditional placebo response by pre-exposure participant to an active drug like an opioid. Therefore, we repeat this study 1 day apart and we observe similar results. You can see in red the placebo arm, in yellow the morphine arm, and in white the controls. In the y-axis, we see again pain tolerance. So no matter if we use a conditioning that is days or weeks apart, we can elicit through a training, pharmacological conditioning in this case, a placebo response. This kind of mechanism eventually can be relevant now that we face the epidemic of opioids as a strategy for tapering opioids in those patients who still need to use opioids and they can't have some other alternatives that are non-opioids based. Another way to learn about placebo mechanism is to use brain imaging and try to understand why eventually when we produce a placebo response we feel less pain and how the brain is tricked by this mechanism. Again, a learning mechanism where people are pre-exposed to a simulation of analgesia paired with different events because we are in brain imaging context where we use an event-related design. So there is a need to simplify the model. So in this case, we use a very fast stimulation to produce pain through a laser. And we pair painful stimuli to a red light and no painful analgesic stimuli to a green light. After several pairings, we replace both DQs with the same identical high level of laser stimulation. The goal was to try to understand how prior experience to something that participant perceived as analgesic can drive placebo analgesia. This difference is the behavioral response. Well, the goal was to try to understand at the level of neuronal responses what become relevant in targeting placebo effects. And indeed, you can see that there are different bold response when same identical painful stimulation were delivered. And this modulation of the red associate bold response and the green associate bold response to identical painful stimulation is what we call a neuronal signature of placebo effect. This was not merely a bias. Indeed, just before the rating, we can target this response that was not related to when we ask please rate your pain. Importantly, the dorsolateral prefrontal cortex account for larger placebo effects. And the more people during the training, that is why I stress that placebo has a big learning component. Those who have larger activation during the training phase show larger placebo effects. Placebo can also be learned through observation. That is something that we started to show in the literature about 1 decade ago, and now with NIH fund, we were able to show the neuronal correlates. So in 2009, for the first time, we demonstrate that merely observing someone receiving painful and non-painful stimulation with our model that I explained can induce in an observer that is tested for placebo just after the simulation larger placebo effects. Indeed, you can see that the observer that were never exposed to prior experience of analgesia, never told that they would feel less pain, merely having observed another person receiving an analgesic treatment produce this kind of analgesic behavioral effects. Until we observe something behaviorally, we are not fully satisfied. So what we did, we translate this in a brain imaging setting. A demonstrator was able again to show two different levels of pain. One cream was perceived as effective when in reality both were Vaseline cream, and one cream was perceived as not effective. While participants in the brain imaging setting observe the video, they activate the temporoparietal junction, and you can see the left and the right area. But also, they felt the appraisal of someone else receiving painful stimulation. In fact, they activate both left and right amygdala that differently modulated by the two treatments. And not just that, they also show a modulation of this hub that I described, that is the periaqueductal gray, that was differently activated when they saw someone perceive analgesia or not analgesia. After this observation, we test them, and again, you can see that the dorsolateral prefrontal cortex become active while they have their own placebo response. Behaviorally, they express a different expectation for the two creams, and also they had a different level of anxiety, suggesting that our intent to create different, expectation around the two treatments work out well. Importantly, when we look at functional connectivity in the brain, the more these two areas, the dorsolateral prefrontal cortex and the temporoparietal junction communicated, the larger the possibility to predict placebo analgesic effects. And we look at functional connectivity during the resting state while they were observing someone else receiving the two treatments. Both predict placebo analgesia. Then the next question was, this must be an important mechanism of observational induced analgesia. And indeed, when we use a mediation model to see why this behavioral outcome of placebo self-report effects occurred, we found that this connectivity was mediating this effect, suggesting for the first time a mechanism responsible for understanding change in the brain occurring as a matter of observing someone else receiving a treatment. Another important component is genetic. And again, we want to know how learning can help to predict placebo response as compared to a verbal suggestion alone. And we studied 3 SNPs that have been published in the literature in relationship to placebo analgesia. These are OPRM1, that is a gene for the mu opioid system, COMT for the dopamine, and FFH for the endogenous cannabinoid system. But also we want to contrast how the interaction of these 3 SNPs, that is the most elementary and basic mechanism to look at genetic, play a role along with learning. You can see that this is the distribution of our carriers for each polymorphism, and these are the behavioral responses that are larger when we create a conditioning. Of course, if we look at 3 SNPs, we can have several combinations of carriers. And you can see that in transparency, we indicate people who didn't experience any placebo response versus people in red and green who experienced placebo effects. There were different magnitude based on different combination of SNPs. But we also look at the psychological component. When we use this receiver operating characteristic curves, the best predictor was the interaction of the 3 SNPs along with the procedure that we use to study placebo, learning versus verbal suggestion. Therefore, genetics can't account, at least with these 3 SNPs, to predict placebo alone. We have to keep in mind that some other psychological and clinical components can be extremely relevant in shaping placebo responsiveness. Another important thing is related to expectation. Expectation, despite the ability to learn, can somehow jeopardize what we had learned. In this case, participants come to the lab, and this was done at NMH. We train people to learn 3 different levels of pain, relatively small, moderate, and high, in association to phase that were in concordance with the meaning of the pain. Fearful with high pain and red light, neutral and yellow light, medium level of pain, low pain, happy phase, and green light. In the fMRI, we mismatch this combination and we set all the level of pain at the same identical 50 moderate level. The goal was to try to understand how a mismatch can somehow interfere with placebo responses and nocebo responses. So when we had the same identical intensity of painful stimulation to a thermos, you can see that when the cues were matched with what they expect and they experience day one, we elicit strong placebo effects, but also negative placebo effects, what we would call nocebo, the negative twin of placebo. However, mismatch their expectation with what they had learned previously, abolish placebo responses, but not nocebo responses. From a neuronal point of view, this kind of behavioral effects that at the individual level you can see here were paralleled by an activation of the left inferior parietal cortex that included the supramarginal gyrus and the angular gyrus. Why is that important? Well, because not only learning shape expectation and placebo effects, but what we experience, and eventually we have this dynamic ability to update our overall sensations. Placebo effects can also occur in patients. So far, placebo research has focused primarily in health participants, but it's very important to translate this in chronic pain patients. These are patients who have primarily orofacial pain, temporomandibular pain, but also a set of comorbidities. We found that we can shape their expectation through prior experience to something like a conditioning. So baseline reinforced expectations. And what is important, placebo effects are extremely similar, with no difference in the magnitude when we compare health participants matched for sex, race, and age, and patients with primary diagnosis of TMD, along with other comorbidities, metabolics, other pain disorders, and so on. Importantly, the rate of placebo responsiveness change. We observe a smaller percentage of responders in chronic pain patients as compared to health participants. But when it comes to what we call the number needed to treat patient, that is very important when we run a clinical trial, the NNT of the placebo was very similar in the range of an NNT of anticonvulsant and opioids, suggesting that placebo can have a very high NNT. Recently, we also focus on racial differences in expectation and placebo. We observe that Afro-Americans, Black people tend to have lower expectation than white in both TMD and health controls. When it comes to placebo effects, we see that only there is a marginal difference in lower placebo effects in Afro-Americans that last only for one trial, suggesting that no matter which race we study, at least for Afro-Americans and white, the placebo are very similar. In fact, no difference at all in health controls, and for TMD, only a difference at the beginning that tended to expose over trials. In terms of magnitude, both Afro-Americans, Blacks, and whites have very large substantial placebo effects. Importantly, there is also a difference between same experimental race and different experimental race, suggesting that disparities and racial biases can indeed have a role. In fact, when the same experimenter and participant share the same race, we see larger placebo effects in TMD. For health participants, become more important the sex of the experimenter. And another important thing is we can model placebo effects when we want to predict those people who are going to respond to placebo. There are different ways from Bayesian modeling. In this case, we use latent class analysis, and we identify that prior experience again becomes so important in determining those who have larger placebo effects. So these are TMD, these are controls, and you can see that based on the cluster that we identify with the LCA approach, we can predict the magnitude of placebo responsiveness. And towards the end, I will be faster because I think I have just a few minutes. It is important to emphasize that placebo are not merely related to sugar pills or inert substances. Any treatment can per se have a placebo component. Indeed, morphine, surgical procedure, integrative and complementary medicine are modulated by expectation and placebo components. This is just an example. We choose 4 different classes of pain therapeutics. The first 2, buprenorphine, tramadol, are opioids, the last 2 non-opioids, pain analgesics. What we observed was that the way we administer a drug, for example, to a pump of infusion controlled by a computer, determined a different outcome in patients who were treated in the postoperative setting after thoracotomy for removal of lung cancer. So in red, you can see the reduction of pain when they were informed. Now we are going to give you a painful an analgesic treatment as compared to the hidden administration. The hidden produce always a lower response. So it is very important to be careful when we inform a participant that we frame the informed consent, the communication around the treatment in a way that empower expectation so that we can enlarge, if we are in a clinical setting, the magnitude of the outcome. On the other hand, if we are running a clinical trials, maybe we want to do exactly the opposite, try to minimize this somehow empowerment of expectation to avoid, this a lack of ability to have an assay sensitivity that allow us to minimize placebo responses. And finally, my take-home message will be a little bit tailored to 3 different audiences: people who run clinical trials, scientists, and providers. So for those who run clinical trials, it is very important to try to understand that what patients expect and the provider expect can jeopardize the outcome. Also, it is important to ask participants enrolled in the trial which treatment they believe they have received, and we call this allocation assessment. Standardize the language used to express the profile of benefit risks, standardize the duration and number of visits, and minimize this to the minimum to avoid an increase of placebo responses, standardize question and prefer structured checklist, and standardize words that they use to avoid adverse and side effects related to communication. For people who are scientists interested in neurobiology or placebo effects, it is important to take into account the right controls group, include the non-intervention arm that is easy, usually in a laboratory setting, much more easier than in a clinical trial, advance a new line of research that are so critical, from genetic to animal studies that are still very low in the literature in terms of efforts to investigate molecular mechanism. Explore more about cluster and modeling approach where we can understand how we can predict placebo response. And of course, it is critical to have a replication study, data sharing consortium that allow us to have large data sets that will help discover phenotypes of placebo responders. And if you are merely a physician who are interested in placebo, try to align patient expectation with the anticipated therapeutic outcome. Consider administer intervention within a positive context. From the smell, the color of the context, but the words are extremely important. Choose careful the words when you inform your participant or patient to minimize nocebo effects, drop out. And finally, patients like to be informed about the nature and the realm of placebo. And video clicks, as we learn through observation, can be powerful tool to inform patients. With that, I would like to thank you, and I hope we have learned together that placebo effects affect outcomes, no matter which kind of treatment we use, pharmacological, non-pharmacological, rehab, I would say. It is important to harness placebo effects if you would like to optimize clinical outcomes in a daily routine practice or minimize nocebo responses in a clinical setting like trials. And finally, learning mechanisms are very important with different implications for scientists, clinicians, and patients. Thank you very much.